to all the viewers of Physio TV. Today we have with us a very eminent speaker, Dr. Simran Kalra. Dr. Simran Kalra today will be talking about Andropause. She has keen interest in the field of health promotion. She has also done her dissertation of her master's as well as her undergrad in the very subject. We are more than happy to have you. Handing over the session now to you.
Hello, Dr. Shivani. Thank you for introducing me. Today we are going to talk about a very controversial topic, which is andropause. Let's start. I'm going to share my screen now. Dr. Shivani, is my screen visible?
Yes, your screen is visible and I think it is on the slideshow also.
All right. Thank you so much. First of all, I would like to thank Sanjeevi College of Physiotherapy for giving me this opportunity to speak about a topic that I am very passionate about, and for all the support that they have given me all these years to pursue certain bit of researching in the same field. So we'll start. So today's topic that we are going to talk about is andropause. So our objectives for today would be to define what is andropause, understand what is the term andropause, what are the equivalent names for it, how andropause happens, what is the physiology behind it, what is the pathophysiology behind it, what are the signs and symptoms that we can recognize and identify in people, how to apply, what are the diagnostic criteria and how to apply those diagnostic criteria. Then what are the precipitating factors, what are the factors that are affecting andropause, and what are the other bodily functions that andropause affect, and in the end we'll also see some treatment and management strategies. So let's start by defining andropause. So andropause is a very simple term. Andropause, if you divide into two parts, according to the Greek etymology, andra means human male and pause means cessation. So basically, it's andropause, human male cessation. If we want to define it medically, andropause is nothing but a gradual and highly variable decline in the production of androgenic hormones, especially testosterone, in the human male, which are also associated with its effects that occur during and after middle age. All right. So one thing that you have to consider here is andropause is characterized by an insidious effect. There is no abrupt stopping of hormonal secretion that is happening, or we don't have a landmark to term that, okay, come on, now the andropause has happened. Like how our female counterparts, we usually have menopause, which we talk in terms of cessation of our periods, our menses, menstruation cycle. We know when it ends, but when it comes to andropause, it's a very highly variable occurrence or phenomena that is happening. Another thing that we need to consider is andropause is not a disease. That's a age-related, naturally occurring phenomena or hormonal milieu that happens in our body, just like menopause. It's just that because we don't have a definitive marking for andropause, a lot of controversies are there which talk about that andropause is a myth, and the acceptance of the same is very less. There are a lot of alternative names for andropause. Most commonly medically used terminology for andropause is nothing but late onset hypogonadism, which is pretty explanatory, and you will read those in a lot of scientific papers as well. Other commonly used terms are ADAM, which is androgen decline in aging male, male climacteric aging male syndrome, male menopause, menopause, and TDS, which is testosterone deficiency syndrome. Now let's talk about prevalence, incidence, and what and why it happens. So why are we talking about andropause? We're talking about andropause because it is one happening, but we are not paying attention to it. To know if it's happening or not, we need to know what is the incidence rate and what is the prevalence rate. So there are studies done on the same, and there's still studies happening even though there are studies that, like, the focus of research in the field is pretty much low. There are still studies which talk about the prevalence and incidence rate. So a study done in US talked about the incidence rate of andropause, which was 12.3 per thousand males every year. So per thousand people every year. So in 1,000 people, 12.3 people will have andropause. This study was done in 2017. Now we have come to 2015. There's still a possibility that the incidence rate must have increased or must have decreased. So it's still something to talk about. Then when we talk about prevalence wise, there are researchers that talk about that 20% of the men in their 60s show biochemical evidence. That is, they show deficiency in the biomarking, which is testosterone levels and androgen levels in their 60s, which also increases to 50% of men in their 80s, which is pretty much high considering if 50 men out of 100 at the age of 80 are experiencing andropause, it is something that we should be focusing on. So why does andropause happen? The main hormone which functions behind the concept of andropause is testosterone, among the other androgenic hormones, but mainly we are going to focus on testosterone. Okay, so we know with age there are changes that happen in our body which starts affecting our hormones and vice versa. That hormone is also responsible for aging, and aging is responsible for hormones. So testosterone decreases after the age of 30. So if you consider the mean age of testosterone peak around 20 years, which is like the highest amount of testosterone a person will have, studies have shown that after the age of 30, as compared to the peak levels, you will observe a decline of 1 to 2%, which is varying to 1 to 2%, and people depending on their lifestyle, you will see 1 to 2% of decrease in their testosterone level. So if every year you are losing 1 to 2% of testosterone from the age of 30, imagine by the age of 40, you already have lost 10 to 20% of your peak testosterone level. At the age of 50, you've already lost 15 to 30% of your testosterone levels. So as testosterone is going to decline with age, we are going to see its effect on our body, which can be negative because of the functioning of the testosterone which is required in the body. Moving along. So let's talk about why are we giving so much focus to testosterone and how it is going to be related to andropause later on. To understand what is the pathophysiology of andropause, we need to first understand what is the physiology of testosterone and male androgenic hormones. So we'll talk about hypothalamus pituitary gonadal axis here. All right. So let's going back to our basics. It's a very simple, if I want to explain it in a very simple terminology, it is nothing but your hypothalamus releases gonadotropin releasing hormone at a pulsatile release after your puberty or during your puberty, which is when the puberty happens. GnRH is released from the hypothalamus, which goes to the which goes to the anterior pituitary, and the stimulation of GnRH to anterior pituitary releases luteinizing hormone and follicle stimulating hormone, which is LH and FSH. All right. So after LH and FSH are released into the system, LH and FSH go to the leading cells of the testes as well as adrenal glands, and they stimulate the production of testosterone. So what happens in testosterone is after LH is reaching testes, there are receptors on testes which are LH sensitive. All right. Once they are stimulated, they convert the cholesterol that we have in our bloodstream into testosterone through a certain enzymatic process. All right. So we require cholesterol, which is then converted into testosterone. All right. Once you have testosterone, it is released back into the system. Now, when testosterone is released back into the system, it is released in two forms, which is a free form and another is a protein bound reservoir form. All right. Free testosterone is very less, like 1 to 2% of the total testosterone that is available. While protein bound reservoir is a maximum amount, almost 98% of testosterone which is made and is circulating in a bloodstream is a protein bound reservoir. So what protein bound reservoirs we have? We have SHBG and we have albumin. Now, testosterone is majorly bound to SHBG and with albumin as well. Now, when we have testosterone in our bloodstream, there's a negative feedback homeostasis that happens. So testosterone goes after your testosterone levels are elevated, it goes back to GnRH and it inhibits the level of GnRH really. So it works on your hypothalamus. So T level will go to the hypothalamus. Elevated T levels will inhibit the secretion of GnRH from hypothalamus, which ultimately will also decrease the secretion of LH and FSH. And in response to that, testosterone levels are maintained. So whenever there is a rise of T levels, there's a negative feedback that happens. So as you can see in the diagram here, hypothalamus is giving you a positive GnRH stimulation to the anterior pituitary, which gives up LH and FSH positive stimulation to testes, which in turn is formulating testosterone. Now, this goes and gives a negative feedback to hypothalamus to decrease the secretion of GnRH whenever there is a elevation of T levels. Now, how does the synthesis of testosterone happens? So what happens is that the cholesterol that we have is grabbed into the leading cells of testes where the formation of testosterone happens. All right, for which the LH is very important. All right, so this is the process. So using acetate, cholesterol is there. Using the enzyme, a lot of enzymes are used during multiple stages of testosterone. Here, I want you to focus on two things. One is star. We'll talk about this because we are going to talk about star when we're talking about pathophysiology of andropause. So as you can see, whenever cholesterol enters the testes, it is then converted into pregnenolone, all right, which is then converted into DHEA, which is a very potent form of androgenic hormone, which is then produced into androstenediol, and which is then produced into testosterone. All right. The other way through which this is happening is cholesterol to pregnenolone, progesterone, and androsterone to testosterone. All right. Now, to understand what is andropause, first we need to understand what is hypogonadism. All right. There are three different types of hypogonadism. All right. Primary hypogonadism, secondary hypogonadism, and combined hypogonadism. So here, how do we determine which is primary, secondary, and combined? Is through the levels of FSH, LH, and P, testosterone levels in our bloodstream, which we will know tell us if it's a primary, secondary, or combined hypogonadism. So in primary hypogonadism, what happens is T levels are decreased, all right, along with LH levels. So both are decreased. All right. In secondary hypogonadism, what happens is the T levels are decreased. Um, my bad. In primary hypogonadism, what happens is T levels are decreased, but LH levels are not decreased. They are the same, but in level 2, the T levels are decreased. In secondary hypogonadism, both are reduced. LH is reducing along with the T levels. And in combined hypogonadism, both primary and secondary hypogonadism is coexisting. All right. So in secondary hypogonadism, T levels and LH levels are decreasing. All right. So basically, pituitary is acting. While in primary hypogonadism, the T levels are decreasing, but the LH levels are not decreasing. That means pituitary is not affected. That means LH is being secreted normal. That means there's some problem with the testis. Now, how to talk about pathophysiology of andropause. Andropause is basically what we call as late onset hypogonadism. This is the underlying terminology or basis of it, and it's easier to understand. Okay. So what happens is due to aging, there are hormonal changes that happen in males, which in turn causes the symptoms of andropause. Okay. So in andropause, it's a combined type of hypogonadism. Considering with age, all our hormone secreting organs are affected, pituitary as well as testes and any and adrenal glands are affected due to age. All right. So if after blood test you're only finding that the pituitary is okay, but the testes are not, or testes are not okay, but pituitary is not, there might be some other cause to it. Also, yeah. So, uh, so now what we are going to talk about is how does testosterone levels are decreasing with age, which is causing andropause. So the main reason for the decline of testosterone ultimately is Leydig cell depletion and affection of hormones on the Leydig cells. All right. So when we talk about Leydig cells, the main function of Leydig cells is to produce testosterone. All right. So with aging, what happens is the hypothalamus pituitary gonadal axis is affected. How does it? How is it affected? So the sensitivity of LH receptors on Leydig cells is altered. It is less sensitive, especially the old Leydig cells are less sensitive to LH. Then the sensitivity of hypothalamus towards testosterone is altered. So it is also reduced. So since the sensitivity of the receptors which are receiving the main hormones is only affected, it alters the HPT axis completely, which in turn causes the abruption or abruption in the flow of the hormones that are required in the body. Another reason is with age, it has been said that there is testicular changes that keeps on happening. So shrinkage of testes is a very common thing that has been reported through studies, along with morphological abnormalities in the germ cells and tubules. All right. With shrinkage of testes, the main thing is that there is reduction in the Leydig cell numbers. If Leydig cells are reduced, obviously automatically testosterone production will reduce because that is where the testosterone is being formed. All right. Another thing is functioning of the Leydig cells is also reduced. So basically, Leydig cells with age is being affected. The quality is being affected, the quantity is being affected. So both are directly and indirectly reducing the testosterone levels in the body. So let's talk about the function of Leydig cells. So dedifferentiation and involution of Leydig cells is affected. How? So there are two reasons. Studies have reported that with age, there's atherosclerosis that happens. So due to atherosclerosis, the hardening of the blood vessels happen. So there is a reduced blood flow to the testes, which starts affecting the oxygen level as well as the nutrition level that the testes require, which gets affected, which in turn affects the cells of the testes and the production and the functioning of the Leydig cells. All right. Then, since we can see here, this is a Leydig cell in the corner and there's a LH receptor. The sensitivity of the LH receptor with age gets affected, especially in the old Leydig cells. All right. So when that happens, even if we have LH, it is not getting stimulated. So testosterone formation, which happens after the LH stimulates the conversion of cholesterol to testosterone is not happening. All right. Now, if we talk about the hormonal impact, so there's a diminished response to LH and HCG, as we have already talked about, as well as there's a decreased secretion of CAMP, which is also required in the conversion of cholesterol to testosterone, which is which is stimulated or stimulated, whose production is stimulated by the LH hormones. All right. Now, when we talk about Leydig cells being the main organ, not organ, Leydig cells being the main structure which is being affected due to aging, and in terms is causing the pathophysiology behind Andropause. When we have already established or given a lot of importance and understood a lot of importance of oxidative stress on our body in general. We have focused a lot, introduced a lot of recent studies and recent influencing people have introduced or talked a lot about the importance of antioxidants in our life, because the oxidative stress that happens in our body is causing our body to rapidly age. Yes, so same thing is happening in the Leydig cells. All right. Leydig cells with age starts developing more oxidative intracellular environment. All right. Which is generated by mitochondria, which is generated by a reactive oxygen species, which is called as ROS, which is coming from mitochondria. All right. So what is happening? One, ROS is happening. Second is due to atherosclerosis, we already know that the blood flow is being affected. Since the blood flow is being affected, what happens is impaired oxygenation is happening, nutrient supply is being abrupt to the Leydig cells, which starts destroying or increasing the oxidative pressure on the Leydig cells, which in turn starts damaging the cells and aging them more. All right. Now, the second thing is with Leydig cells, what happens is there is a direct cellular damage as well. One we are talking about is through atherosclerosis. The second is the ROS that is happening inside the cell is also causing the cellular damage, which is in turn causing the death of the Leydig cells. Okay. When that is happening, the production of the testosterone is being affected, because one, the cells are dying and cells have to focus more on preventing the cellular damage, as well as the stereogenesis function is also getting affected because of the increased oxidative stress. So the environment is very oxidative inside the cell, which starts affecting the intracellular redox balance. When the redox balance is affected, it starts affecting the formation of CAMP. Now we have already understood that LH stimulates the production of CAMP, which happens inside the Leydig cells, which is important for the production of testosterone through cholesterol. If the formation of CAMP is being affected due to the redox balance impairment, then ultimately the testosterone formation from cholesterol is being affected. Another thing is cholesterol needs to travel from outside to inside. All right. The whole process of the cholesterol transport is also being affected because of the impaired cellular redox. Okay. There are also studies which talk about um, reactive oxygen species that's affecting the DNA formulation, protein formulation, and lipid formulation in general, not pertaining to testes in the body. It causes a damage at the cellular level by increasing the oxidative pressure and making the intracellular pressure in a manner where the cells have to focus more on fighting, which causes damage and ultimately a lot of death, which in terms is what we call as aging at cellular level. Okay, so this is one factor, or yeah, oxidative stress is one factor which is affecting the Leydig cells, which in turn affects the testosterone levels. The other factor was with aging, there's a morphological changes as well as the sensitivity changes that are happening in the receptor changes that are happening in the body, which is also affecting the production of T levels. The other thing that we're going to talk about, which is we already talked about this. So gonadotropin releasing hormone is released from hypothalamus. So during puberty, there's a lot of production of GnRH, which in turn starts the pubertal axis, which is the gonadotropin releasing, which is the hypothalamus pituitary gonadal axis. All right. After which, GnRH is continuously produced in the body at a pulsatile rate. All right, of around 1 to 3 hours. All right. So it is continuously released, which in turns stimulates the LH and FSH level, which, according to research, are not pulsatile. There's a pulsatile secretion, they are maintained. Now, with age, since the hypothalamus, there's a change in the sensitivity of hypothalamus towards the testosterone, it starts affecting the secretion of gonadotropin releasing hormones. Second is there is an alteration in the pulse amplitude, which is basically the one after if there's a pulsatile release of GnRH hormone every 1 to 3 hours, which it gets altered. So the amplitude itself gets altered, which starts affecting the frequency at which LH and FSH are being released in the body, which then affects the release of the testosterone. So when we talk about the oxidative pressure or oxidative stress that is happening in the lighting cells. So this is a lighting cell. Now Ross, okay, so there is already a theory of aging which talks about oxidation, which is happening, okay, excluding the environmental factors, that is already happening. But we also know that a lot of environmental factors are also affecting this process, which increases the oxidative stress and increases the aging process in the body. Okay. Then when ROS happens, look how cholesterol is being transferred to mitochondria, which then goes to the synthesis process and gives out testosterone. So ROS hampers this process of the travel of the cholesterol by affecting the star. And CNP production is also affected because of ROS, which in turn affects the production of testosterone. Now, let's talk about the precipitating factors. So with healthy aging, there is going to be a decline of testosterone anyway. But if we have an unhealthy lifestyle, the reduction in the levels of testosterone can be altered, can be increased or decreased, or which in terms can show us more clinical symptoms and signs of andropause. So what are the precipitating factors? Aging, chronic diseases like diabetes, hypertension, cardiovascular diseases, and obesity, which all these diseases, when happens and are chronic in nature, takes a toll on the body, which in turn starts affecting the anabolic and the catabolic hormones of the body. So, considering testosterone is one of the main hormones of the body, it starts affecting the T levels. Then psychological stress, increased cortisol level due to stress, depression, anxiety suppresses the production of testosterone, which in turn gives us andropause symptoms, of which stress, anxiety, and depression are also symptoms. So it's like a cycle. Unhealthy lifestyle, poor diet, alcohol, smoking, lack of physical activities, all of which starts affecting the body. Increased production of fat, increased oxidative stresses on the body, increased uh, decreased muscle mass, which in turn starts affecting the levels of testosterone. Then sleep disorders, sleep apnea, poor sleep quality reduces T level. So sleeping is the time when our body replenishes all the hormones that we require throughout the day. So that's starts getting affected. Then there's a circadian rhythm of testosterone, which can be affected if you have sleep disturbances and disorders, along with melatonin is known to have an effect on the levels of testosterone in the body. So chronic inflammation, metabolic syndrome, autoimmune diseases, disruption hormone, etc. And genetic factor. So basically, we are considering genetic factor here because we know that obesity can be genetic. We know that there's a chance of sudden onset of hypogonadism or certain symptoms, certain causes like that, which can happen. So it's always better to know any metabolic syndrome or chronic diseases which has a genetic factor can in turn lead to andropause. Andropause is not genetic in itself, but the precipitating factors can be genetic.